Welcome to the APAPP podcast. My name is Rhea Votipka. I'm a nurse practitioner in Burlington, Massachusetts at Lahey Hospital. I'm also the current president-elect of APAPP, and we're happy to have you guys here today on the podcast. We will be discussing hypertensive emergencies with Lora Lonidier. She is one of the members of the Critical Care Committee, as well as a nurse practitioner in Jackson, Mississippi, where she works in pulmonary and critical care medicine. She's also been a longtime member of APAPP and has been integral in all the work that we've done on the Critical Care Committee. So hopefully after this podcast, if she inspires you, you can also join within the Critical Care Committee as well. Welcome, Lora. Thanks for coming.
Thank you. So it's nice to be here. Yes, I have thoroughly enjoyed being a member of the APAPP, as well as just the critical care. There's so many things that's being done around the whole, I guess, the United States that it's not done in my little area of Mississippi. So it's nice to see what other people are doing. So.
Yeah, absolutely. Well, we're just going to go ahead and jump right in. And we're going to start with just basic definitions of what is hypertensive emergency. And do we call it hypertensive urgency, severe hypertension? Yeah, let's just start with some definitions.
There are some changes that have occurred. The American Heart Association has changed some of their definitions, but hypertension emergency is still maintained as a definition. But if you compare emergency and urgency, they're essentially the same when it comes to the blood pressure parameters of 180 over 120. Anything greater than that is a hypertension, either urgency or emergency. Where it becomes an emergency is when you have damage, new or extending of current in organ damage. So if you already have renal failure and it's got worse because of your blood pressure being elevated. So that's really the only defining and key determinant between emergent and urgency is you have new or worsening of your in organ damage.
Right. And who are those that are going to be most at risk for this?
Well, that kind of a lot of possibilities and factors can influence that.
Mm-hmm.
Number one that most people is medication noncompliance.
Right.
It may be they don't know they have blood pressure problems, or it may be they just didn't realize it was a medication they need to take. Because it's one of those diseases, hypertension, that, it doesn't hurt. You don't feel better with medicine. You don't feel worse without the medicine.
Mm-hmm.
So, but a lot of that is medication compliance. Sometimes it also has to do with their lack of insurance, lack of funds, lack of, following up with their primary care providers, even the lack of knowledge of what hypertension and the risk it can do for you or to you. Other people that are more prone to hypertension emergency are those who may partake in illicit drugs like cocaine, methamphetamines. There are some other drugs that put us at risk that we take. Glucocorticoids, nasal decongestants are all put you at risk of having emergencies.
Aspirin will get you.
Every time. Love it, but So, and then people that may have withdrawal syndromes, they'll have emergency from alcohol, either from benzos, even cocaine, or clonidine, excuse me.
Oh, yeah, clonidine.
And then people that partake in excessive sodium intake, if they have other things like endocrine emergencies, like a Cushing syndrome, heart failure, stroke, renal failure, and then, of course, men are usually more prone than women, and then, unfortunately, our African-American population are more prone to the emergencies than other populations. So,
yeah, it seems that, many of these medical problems, those who are at risk are all this kind of the same population, and so we really have to be hyper aware to make sure that we can do everything we can to prevent these issues. And as you were saying, with these medications, sometimes people will take these medications and they feel bad from them.
Yes. Mm-hmm.
And rather than have a conversation with the PCP, or maybe they can't get in touch with their PCP, they just stop taking them.
Yep. Mm-hmm.
And so I think it's really important, as you were saying, to have that conversation, help them realize all the side effects that can happen if they're not diligent in being on top of the medications that they're taking.
Yep.
What if left untreated and someone is not taking their medication, or they take one of these drugs and they're developing this hypertensive crisis? What happens? What's the complications that can happen?
So one of the things it has to do with is why does it occur to begin with? Some of those factors that development is when you look at the pathophys, there's usually an abrupt rise in their systemic vascular resistance, and that affect with a bunch of other pathological effects. When you have vasoconstriction, you have a activation of your renin-angiotensin system, and then of course that further increases the pressure and resistance. You have your endothelial injury and dysfunction that has a disruption to the vessel linings, and then of course that disrupts your audio regulation. All that adds to having an end organ failure. And that's what happens. Then they come in with all these comorbidity events. But with the disruption of that autoregulation, the body has a built-in, system to try to help manage it. But when it's a continuous hypertension or it becomes emergent, then the body just can't handle that. So again, you have end organ failures, different systems.
So now let's talk about when someone has this disease process, what complications can happen if it's left untreated?
Okay. Without going in detail about the pathophysiology, there's a components of increased pressure that ends with vasoconstriction. Then you have damage to your endothelial dysfunction of that lining of your vessel. And then, of course, that impairs your autoregulation. And that's what leads to a damage to the organ. Automatically, the organ has like an autoregulation that kind of helps protect the organ from high blood pressure, and the body gets used to that level. So what happens is with that vicious cycle that occurs with, high blood pressure, the organ can't handle that, then of course, then you have more damage. So it's just a vicious cycle. So some of the things we see with those organs, there's a mnemonic called BARC-H.
Okay.
And how to keep up with what organs may be damaged. When you think about the B, it's brain. And the things you see is like stroke, ischemic, ischemia, the ICH, press disorder. A is for arteries. The biggest one is dissection. Then you also have other things like preeclampsia and eclampsia falls under that. And then you have the R, which is your retina. Not something we really assess a lot in the acute care setting. I don't know about most people, but finding an otoscope or ophthalmoscope in the hospital is pretty rare. But there can be hemorrhaging, and that can lead to other things, papilledema, vision loss, even blindness. And then you have K is for your kidney. We see them come in with acute kidney injury. And then, of course, H is for the heart. Your coronary disease or your acute coronary syndromes, your heart failure, pulmonary edema. So those are the kind of the systems you see that start having end organ failure because of extensive hypertensive emergency.
And it makes you wonder, as clinicians, when we hear these things, these are really major complications. These are really life-altering complications. Mm-hmm. And you wonder if when patients come in with just a mildly elevated blood pressure, if they truly get the education to really understand that if left untreated, they can truly have life-altering complications. Yes. And, I know sometimes we may not have time to have those conversations, but really, I think if we could help people understand at the base level with just mildly elevated blood pressures that, hey, if you can manage this well, you can have you can really have a much more quality of life rather than if left untreated, than having to deal with, blindness or, unilateral weakness from a stroke, those type of things. And so I think it'd be really beneficial if we could do, as clinicians, just a more clear job of educating those who may not understand what the end game is if we don't do a good job of treating it.
That's true. Mm-hmm.
So then let's pivot a bit and kind of talk about a patient coming in and what kind of presentation might you see, and how common is it? Are we expected to see it often? Are we expected to see it a little bit? What does it look like when a patient comes in like this?
Okay. So, of course, it's really going to be a wide range of signs and symptoms can occur, and it depends a lot of times on which organ has failure. Mm-hmm. Some of the signs and symptoms that when they present to the emergency room or to present even to their local providers before they're instructed to come to the emergency room, a lot of them they're complaining about headaches. They're having neurological deficits. They're having weakness, complaints of headaches, vision problems. They also are having seizure activity, altered mental status, chest pain, shortness of breath. Some will come in complaining of nausea and vomiting without any understanding. nosebleeds if their blood pressure is too high for some people. They'll even complain that they're not able to void or there's changes in their urination. And some of the things that majorly we see is the strokes is one of the big ones, aortic dissection, and for the pregnancy patients, it's the preeclampsia and the eclampsia that occurs. And then, of course, with the acute kidney injury. So those are the neuro, the cardiovascular, and the renal are the three main organs that usually get hit with hypertensive emergencies.
Like you were talking about with the BARC, and an acronym that you were giving, yeah. So when you have a patient coming in with these symptoms and you have a blood pressure that's elevated, what kind of questions are you going to ask them? What kind of physical exam are you going to do?
Okay. I mean, when you start talking about how you structure your exam, everybody has their own way of doing things, and it helps them remember and not miss steps. The true key to diagnosing hypertensive emergency is first you got to be rapid and responsive, and then of course you got to have a thorough evaluation. You're going to focus on that neurological, the cardiovascular, as well as the renal. History is the main thing. You got to have a good history. I initially start off with, because I'm in an acute care setting, they're going to usually show up in the emergency room. If I don't see them in the emergency room, I usually see them in the ICU. And I usually ask them, what brought you to the emergency room? What was going on? And then what made you seek medical attention? And then I tend to go through the PQRST, what provoked it, what quality. I want to look at, is it localized? What region? Does it radiate? The severity? Look at how long it's been going on, the time. And of course, then you want to talk about more detail about what their past medical history is. This part can be a little tricky, because your patients sometimes will remember things. I'll ask them, have you ever had a stroke? And if they do, I want to know if they had any residuals left over, because if they have a left-sided weakness from an old stroke, well, then that's not new. I ask them if they have high blood pressure. I'll ask them if they've had heart problems, like have they had a coronary artery disease, where they've had been told they had an MI or had any stents placed, smoking, any shortness of breath. And sometimes you have to be real creative with patients, because I've asked patients before, do you have any health problems? No. Mm-hmm. So you don't take any medicines
but
every
here's
day?
My 50 medications.
Yeah. You don't take any medicines every day? Oh, well, I take a little medicine for my blood pressure, but it's not a problem now. I said, but you still got high blood pressure.
Yeah.
So, and then unfortunately, sometimes you can ask patients, do you take any medicine? They'll say no. And then I'll say, well, when's the last time you saw your primary care provider? Oh, I hadn't seen him in 30 years. Well, there's a hint. You probably have some health problems, but you just don't know it because you haven't been to the doctor in 30 years. So, but you do have to, you just can't expect the patient to, give you all the information. Sometimes you do really have to dig. Do you have sleep apnea? Do you snore? Do you smoke? Do you take, drugs that are not prescribed? And then I ask you, do you drink? How much? Do you do it every day? Because unfortunately, 2 beers never means 2 beers.
Yeah.
And then now we have a little bit more, with the new marijuana card and prescription that patients have. A lot of times I have to ask, well, what were you prescribed that for? Or what are you obtaining marijuana for? Because that may lead to giving me a few more hints about their health.
Right.
So the biggest thing to remember when you're doing your history is you got to be non-judgmental.
Right.
And I have to tell them all the time, look, that's your business, what you do. I just have to know a little bit more. I have to have a very thorough information about your history so I know how to treat you better. So, but then of course, then you go from the questioning and answer period to more of an exam and looking for your end organ damage. What is their mental status? Are you getting the questions answered from the patient, or is the family having to answer for you because they're unable to? You have to do a really good cardiac, pulmonary, and renal exam, and neurological even. So you're looking for edema, you're looking for crackles and rails when you listen. Do they have a murmur? Are their pupils equal? Do they remove their extremities equally? And then, of course, the other process is look for other things that maybe the family can give you hints for. So, because sometimes they'll tell you things that the patient's they're not going to be quite honest enough to tell you. So they're not willing to tell you. So.
Well, and sometimes, as you know, our patients can't speak, right? If they have confusion related to the hypertension. Yeah. So that can definitely play a role. Any other diagnostics that you might do as you've done your physical exam, targeted diagnostics as you're working these patients up?
Yes. It's almost like you bring out the whole book and get the rainbow of lab work. The biggest thing is you want to look at your BMP, your chemistries, because you're looking for a renal failure. You also want to do a urinalysis, because that's also an indication of renal injury. You're going to get a CBC, and you want to get a peripheral smear because you're looking for hemolytic anemia. Then also you wanted, if they've admitted to it or not, if you have a suspicion, you need to do a urine drug screen, because you're wanting to see what drugs that may have contributed to this. Because, most of them, when they come in, if there's that acute status going on, they're not going to be able to tell you they even use drugs. So, the drug screen at least give you an indication they don't have cocaine in their system. And then, of course, with women of childbearing years, you want to do a pregnancy test. It is amazing. And maybe it's just in the state of Mississippi. I don't know. But some people do not realize they're pregnant. So we have to check that, especially because before you start medications, you want to know with their child, if they're with child. A troponin and a BNP are also some good things. You're looking at your acute coronary syndrome and also to see if they have any heart failure symptoms. An EKG is a good start. You're looking for, injury for LV hypertrophy, any ischemia, arrhythmias, and a chest x-ray. Those are just the basic. The chest x-ray, you're looking for cardiomegalia. You're also looking for the mediastinal widening, any pulmonary edema process. And then depending on what their symptoms were, you may do a CT scanning. Any neurological, headaches, vision problems, you're going to get a CT of the head. Because you're looking to make sure there's nothing that may be causing that. And then, of course, CT of the chest, if there's something abnormal in your chest x-ray, or if they have mediastinal widening. So there are other things that may be done to look for other complications that may be added to that, but it's usually after everything else has been ruled out. So.
Okay. So now we have our patient. Hopefully at this point we have our diagnosis, or we're working on getting our diagnosis. Let's talk about managing the blood pressure, because their blood pressure is going to be high. And I know you mentioned this earlier a bit about autoregulation, but how does that affect how we start to manage our blood pressure?
Okay, yeah. The autoregulation is the body's protective measure of trying to help that organ have a continuous regulatory flow of blood. And when your body has been having hypertension, whether it's chronic or not, then it actually has reset your autoregulation range. So the body now has got to where it accepts a higher pressure. So with that happening, you have to be careful when you start doing management. Can you lower the blood pressure faster? Should you lower it faster? Or does it need to be a more gradual decline? And most of the time, there are situations that you need to do faster, but some of them you want to do it slower so the body readjusts to that. There's better autoregulation. Because without it, you actually have a risk of causing more damage to those organs, because now you've caused them to have some hypoperfusion. So now that organ's not getting the blood supply it was used to. So as a general rule, you want to do slow, controlled blood pressure reduction so you don't cause more damage and you allow that autoregulation to actually start the process, because too rapid will cause more problems.
Right. So then what drugs are you going to use?
Well, let me preference it by saying every provider's different. There are a lot of guidelines out there. You do have other things that affect that. Hospitals, what they are willing to pay for certain drugs.
Correct.
The type of medications they have. There are some that, because of their cost, they're limited to certain type of patients. That they may only can use it in the ICH patients or the cardiac patients. But the biggest thing is you got to make sure some patient situations actually will dictate. But personal preference, usually with the drugs I go to, is always going to be intravenous. You're going to have to do continuous with a hypertensive emergency. You need to start medications that are going to be implemented. You can do some pushes, but you need to start that infusion. And the most, because of the hypertensive emergency, you want to decrease your MAP gradually by 10 to 20% in the first hour, and then a 5 to 15% over the next 23 hours. There are some exceptions. Your strokes, ischemic strokes, those who are going to get perfusion therapy, which, your thrombolytics or your thrombectomies, you want their blood pressure less than 180. And then for those who are not going to have reperfusion, those of us that get a little upset about blood pressure, it's 220. You walk in and see that. And then like aortic dissections, you want their blood pressure dramatically. There's the ones that you want to drop faster. You want that blood pressure 100 to 120. And usually within 20 minutes. Intracranial bleeds or hemorrhages, that's also one of those that's a little bit faster. And usually the goal is 140. But usually after the 8 to 24 hours of the blood pressure being controlled, you may want to start some oral agents and stuff.
So with that, do you have go-to medications that you start with? Because you talked about, as we talked about earlier, patients are affected by what they can get as far as medications. So are hospitals. So what kind of treatment do you do? Do you start with an IV push and then go to a drip? How do you manage these people?
If you look at the bark, H, again, with the brain, usually labetalol is a push. We do start with that, and it's usually about every 2 hours. But then cardine is started. Now, for intracranial hemorrhage, clevoprez a lot of times is used. Again, at one of my hospitals is not used at all, and then one of our other hospitals that is limited to our neurosurgery patients, which is our bleeds. If it's for the arteries, esmolol for a dissection is paramount, and actually it's pretty much the standard. Right. You can use other things, nitroglycerin, nipride, cardine. There are some more pushes, but initially you start with infusions. You can add some pushes to be in addition to the continuous, but usually it's infusions. Now, retina, there's not a whole lot of emergencies. That's not initially what brought you to the hospital, but for the kidneys, again, we go to cardine, clevoprez, and there's a medication out there called phenoldiprem. I've never had any access to it. It's chlorapam is the other name for it. But it has been told to actually benefit the renal function. So,
and is that a continuous infusion?
It is a continuous infusion, limited like 48 hours. Mm-hmm. And then the heart, nitroglycerin, nipride, clevoprez, esmolol, not usually what I see a lot for, coronary problems, but it can be a possibility. So,
and for these patients, are you putting in an A-line in some of these people? Are you not? I think that's sometimes a big question with them, right?
It is. And I guess with the big push of people that lines are bad, all the risk of infections,
right?
And normally we don't do a lot of A-lines, mostly because we want them controlled in 8 hours. There are situations, if you have a patient who has only one arm, and their one arm is the one that has a AV graft in it. Well, cuffs are not going to work, and you really don't want to put them on their legs. That's not as accurate. So there are sometimes you have to put A-lines in. Now, I suspect it's going to be seen more in the future. There was 2 studies. One was in 2023. Its journal was the West Journal, England, in 2023. Talked about arterial monitoring in the patients who had hypertensive emergencies. Now, it was a very prospective observational study, like only 212 people, but they were looking at the discrepancies between a cuff and an A-line, and they found that there was a 17 millimeter of mercury difference, showing a 40% difference in discrepancy between them. So when you're trying to titrate medications and they're thinking that the non-invasive is not giving you the accurate reading, then there may be something to it. And then the American Heart Association in 2024, in their recommendations, also found that there may be a difference in the systolic and diastolic 50/30, in the blood pressure. So they're also starting to recommend an arterial line. So I think it's coming.
Yeah.
But whether it's accepted, because again, most people are, and you hate putting in lines for somebody that hopefully in 8 hours or 24 hours you're going to be back on oral agents. So.
Right. And I think also in my practice, a lot of it is very patient specific. Mm-hmm. If their blood pressure is all over the place, if they're a very labile patient, and not that the organs that we talk about are affected aren't major organs, but if they're having an MI or their brain, things that are much more devastating, I guess, where you're seeing that really they're having some ischemia, whether brain or heart, I think those are the people that I'm more inclined to do an A-line when bigger organs are involved and the blood pressure is very difficult to control, because I just want to make sure that I'm really doing a great job of keeping it where we want it. So I think that's just part of the art of medicine. I agree with you. There are some people who don't need it. And they're responding really well to the treatment that they've been started on, and their blood pressure is textbook. But there's always the people who don't read the book, right?
That's true. Oh, yeah. Yes.
What about, so you mentioned, the hope is that it's a short-term stay. And then what about when do you consider restarting oral agents on these patients?
Of course, it depends on the patient, but usually if their blood pressure control within 8 to 24 hours, then you do restart oral agents. We do tend to start with their home meds, if appropriate. I'm not going to start them on medications that, like an ACE inhibitor or hydrochlorothiazide, if they come in with acute kidney injury.
Right.
So sometimes you have to be selective. I also, when you're taking that history and you find out and ask them, well, why did you stop taking your blood pressure medicine? There's all kind of reasons they stop it. But if they tell us it's because they can't afford it or it's because of something that was, affecting other things. I have a lot of men that some medicines are stopped because it affects areas that they don't want affected. So, but so those are things that you kind of need to avoid because they're already revealed they're non-compliant with it, and that is part of their life, and you want to make sure you have the appropriate drugs. But yes, now some of the patients you got to be careful about is those who have a stroke. Of course, you got to make sure before you start oral agents that they can swallow, they pass the evaluations, those kind of things. But yeah, usually within 24 hours or at the 24-hour period, you do want to start implementing oral agents if the blood pressure is controlled. If you're still really doing a lot of titrating on those continuous infusions, you can add them, but you're not going to be ready to titrate or, remove the continuous. So,
well, and I think you brought up a really good point that, at least from a critical care perspective, because so many of my patients can't communicate with me, I think it's very easy to get in the habit of just restarting drugs and then going about my day rather than doing that investigative piece, asking them the questions. And sometimes it's questions like, patients may not be willing to share the reasons why they don't take it.
That's true.
And we have to maintain again, not being judgmental and really just being open and having that conversation of, okay, is this medication working for you? Why is it not working for you? And there are so many meds out there. There's probably a medication that might work better. And having that open and honest conversation, because that is going to be what's best for the patient, not just saying, why aren't you taking this med? You need to be taking it, and because that's not how people work, right?
Writing them is not going to make them take the medicine.
Exactly. So I think that's such a really important point to bring up is, you may not, when they came in, maybe you couldn't communicate that with them, but as you're restarting it, facilitating that conversation and making sure you're starting them on something that they're willing to take and can afford, right? These are things that we really do have to consider. And for those of us in the ICU, so many times we start a medication and it just keeps continuing on, and maybe that's not the best drug. So I think also as critical care providers, we have to be mindful that the things that we start can play a downstream effect as patients continue through the hospital and get discharged.
That's true.
So I know in our conversation, you have talked about essentially, this is where the art of medicine comes in, where choosing the correct medication, the correct drip, it depends on the type of organ that's affected by the hypertension. And you hit on this a little bit, but I wanted to just have a brief discussion about what about somebody who comes in and they're pregnant and maybe it's looking a bit preeclamptic.
So yeah, those are, I usually ask they go to some other hospital, but they don't usually do that. So when you talk about preeclampsia, there is a little difference. They're considered hypertensive emergencies, but their blood pressure is a little bit definitively different. Their diagnostic criteria is for their systolic blood pressure, if it's greater than 140 or over 90 for two occasions, at least 4 hours apart, and they have at least one new finding, which is proteinuria. Their platelet count is less than 100,000. Their serum creatinine has doubled when they didn't have a disease of kidney disease initially, if they have liver transaminase is twice the upper limit of the normal, or if they have pulmonary edema or any new onset like a persistent headache or changes in their vision that are that's not being improved with the normal medications or analgesics, then those are considered to have an emergency that needs to be addressed. Most of the time you use hydralazine and labetalol. Both of those are pushes. But if that's not controlled with that, then cardine. And then in some findings, I found that phenaldiprime is also being used. But with those, you have to be a little bit more, you have to be pretty careful and pretty more aggressive. You don't want a blood pressure 180 over 120 for somebody who's pregnant. And preeclampsia or eclampsia, that can occur, anytime after 20 weeks of gestational, up to 6 weeks after the birth of the baby.
So we can certainly see these people, especially postpartum in the ICU.
Yes, we do.
So we've talked about identifying the patient, managing the patient. What about after they leave the ICU? What are we doing for them to set them up for success?
Well, initially, depending on what they come to the hospital for, then you're going to do a lot of consults. If they come in with some end organ that affects their brain, if they had a stroke, neuro's involved. If they've had a bleed, we get neurosurgery involved. If there's a dissection of the ascending, of course, you want cardiothoracic because that's usually an emergency.
Right.
And then, of course, if it's a descending aorta dissection, depending on if it has, it's maybe causing some of the end organ damage, or if it's not, will depend on what vascular consults. And they will depend on whether they just want to do medical management and follow them, or do they need to do a stent or graft of some type? If it's the kidneys, we get the nephrologist on board. If it's the heart, we get the cardiologist on board. And during that interview and during your hospital stay, hopefully you will find if there's any kind of social indeterminates, then you need to get case management involved for discharge planning, medication assistance if that's needed. And in some situations, unfortunately, it may be housing. Some patients are homeless, and that's part of the process, one of the indications of why they're not been taking their medicine. So,
yeah, set them up for success in the future.
Okay. And before we forget, you talked about it, but let me talk about the conversations.
Okay.
Before you have a patient's discharge. We talked about, these are the fun conversations, of course. You want to make sure patients understand what hypertension does, what the risk factors are. It's called the silent killer for a reason. I try to explain to the patients that, you're not going to feel bad with it. Initially, you will feel bad after you start taking blood pressure medicine because you're used to this high blood pressure. But over time, you're not going to notice the difference if you stop taking the medicine because it's not like, you take it and you start having chest pain for like coronary syndromes. But some patients, you just have to explain to them the risk. And hopefully when they come in with the problems they found, then they'll say, oh, well, maybe I need to take the blood pressure. Then you have to go through all those. You can do this, you can't do that. You're the mama. You can't smoke. You need to lose weight. You got to increase your activity. You need to follow up. Quit doing your drugs, all that kind of stuff. If they have sleep apnea, you need to make sure they follow up with their specialist. You need to follow up with sleep apnea specialists. You also, if you have been diagnosed, you need to make sure they understand the importance of being on the CPAP machine. You just need to address any of those concerns and talk to that patient and the family. And I usually do that every time I'm in the room, just about. Especially if there's a family member that can influence them a little bit better.
Of course.
So, but yeah, it's knowledge is a power for sure. And if the patient and family know the importance, then hopefully they'll be more compliant. But sometimes if they have to choose between blood pressure medicine and paying their rent, there's always concern.
Of course.
So,
yeah, I think those conversations are really important. And as you were saying, setting expectations so that they're not surprised when they start taking the meds and things don't feel normal. And so I think if we set expectations, hopefully they're more likely to kind of stick with it.
Yep.
So, Lora, thank you so much for your time. That's all the questions I have.
Okay,
I think you've covered this was such a huge topic. And so you covered it really well. I really appreciate you giving your time and for all your involvement in the Critical Care Committee and APAPP in general. So thank you. And then I'd also like to thank Kiesi for their support of APAPP education and through their unrestricted medical grant to allow for this podcast to happen today. So we're so thankful for them. And for all those listening, Please continue to follow APAPP on your social media, like and subscribe, and come to our conference that we have every year. We look forward to hearing from you. Thank you. Bye.
Bye.